This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. Did you know live Senate video is now available at youtube.com/@Senate of Virginia. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B306. Did you know live Senate video is now available at youtube.com/@Senate of Virginia? This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B306. Did you know live Senate video is now available at youtube.com/@Senate of Virginia? This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. Did you know live Senate video is now available at youtube.com/@Senate of Virginia? This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. Did you know live Senate video is now available at youtube.com/@Senate of Virginia? This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306. This is the Senate of Virginia, Richmond, Virginia. Senate Committee Room, B 306.
Afternoon. Welcome to the Commission on Women's Health. My name is Delegate Candy Munden King, and I'm the vice chair of the commission, but will be helping to drive things today. We are going to start with our roll call, and I'll let Jillian take it from there.
Delegate Munden King.
Present.
Delegate Tran. Delegate Simons. Delegate Anthony.
Present.
Delegate Tata. Here. Delegate Kent.
Here.
Senator Locke. Senator Aird. Senator Perry.
Here.
Teresa Nicole Bremby. Natalie Shorter. Kenda Sutton.
Say something.
Say something.
Denise Harris Proctor, Stacy Brayboy, Senator Lucas.
Here. Thank you so much, Jillian. We have some great presentations today. And first, we are going to start with Dr. Lewis from EVMS. And I'm a proud EVMS kid growing up in Portsmouth, but Dr. Lewis became the Dean of the Brock Virginia Health Sciences in September 2025. Dr. Lewis is board certified in maternal and fetal medicine and in obstetrics and gynecology, has extensive leadership experience in academic health, and is fellowship trained in maternal fetal medicine, which is something this committee is very, very interested in. And research includes the study of obstructive sleep apnea in pregnancy. And Dr. Lewis, we will give you the floor.
Thank you. Thank you so much. First of all, thank you for giving me this opportunity to present really not just the work that is this better? Okay. Thank you so much for the opportunity to present the work that I do, not just in terms of research, but also in improving the health of families all across the country. So as stated, I am the new Dean of Eastern Virginia Medical School at Old Dominion University. I started September 1st, so brand new to the institution and brand new to Virginia, and I am very glad to be here. So the first question of who am I other than being the dean? I have spent my career, I finished fellowship in 2007. Since then, I have worked as a high-risk obstetrician, caring for the most complex of pregnant patients, and also taking care of them postpartum. I also am a researcher. I am a fierce advocate that advocates for policies and clinical changes that will improve maternal morbidity and mortality. I work extensively with communities and towards community engagement, access to care, and more recently, especially since COVID, advocating that pregnant women are included in clinical trials so that we have appropriate treatments for them. On the personal front, because it does impact the work that I do, I am the mother to former preemies. I gave birth to twins that were delivered at 25 weeks. And so because of that, I am very passionate about science and how much we have benefited from science. Those twins are doing great now. They are freshmen in college. I grew up in a low-income family, so I've had a firsthand experience about the difficulties in accessing health care. I am the proud daughter and spouse of immigrants, so if I ever wanted to forget about their struggles, I'm not allowed. I have spent my career caring for the underserved populations in every city, and that has been by choice. I have worked extensively across states to work with different hospital systems and healthcare professionals to improve care, and have worked in both rural and urban populations. I share all of this to share the context of the work that I want to do here in Virginia with the medical school and with all of you. So I was asked to talk about my research a little bit, and I do study sleep apnea in pregnancy. When I first wanted to study it, there were no obstetricians studying it, and it was thought to be sort of a risky proposition because people did not take sleep seriously. So when I was asked, why do I want to study sleep? Think about it. If you sleep how much you're supposed to, that means that's about a third of your life. There was clear evidence that sleep is not a passive state, that things actively happen during that time. And when you looked at people who were not pregnant, where there was abnormal sleep, there was clear scientific evidence that there was more illness, more mortality related to abnormal sleep. And at the time, we were not making any progress in maternal health, in improving morbidity and mortality. So I asked, are we missing a risk factor? Could sleep, particularly sleep apnea, be the factor? So, this figure is one of my most favorite figures because it highlights the point that people think of sleep apnea as just this one disease, but it's really part of a spectrum, that it starts with snoring. Snoring is not normal, right? You snore because your airway is collapsing. That's the mild version. When it gets severe, your airway collapses and oxygen doesn't get through. Your body responds to the lack of oxygen by waking you up. And so all you know is that you didn't sleep well, but you may have sleep apnea and your body is responding to the fact that you have sleep apnea. So I decided to study in pregnancy those who have sleep apnea. If you look at sleep apnea as a whole, it has a lot of impacts. And so this figure is one that they published in 2016 that talked about what's the societal cost of sleep apnea, recognizing that up to 90% of people who have sleep apnea don't even know they have it. They just know that they snore or that they don't feel well in the morning. But we know that if you have sleep apnea and it's not treated, you're more likely to develop high blood pressure, diabetes, insomnia, depression, and anxiety. If you know, I'm a big road tripper, I don't know if anybody else is, but sometimes you will drive in certain states, you'll see billboards on the highway asking truck drivers if they've been screened for sleep apnea. That's because they found a lot of clear evidence, irrefutable, that dates back to the 1970s that people with sleep apnea are more likely to get into fatal and non-fatal automobile accidents. So that's where we have clear evidence that if you have untreated sleep apnea, you're more likely to get into an accident. And so certainly we want people who have the condition to be treated. The other reason to study sleep apnea in pregnancy is that we know that obesity has been increasing and that it is very tied to sleep apnea. This is a figure from one of my publications where we looked at the occurrence of obesity in pregnancy over time, and that's the line in blue. And then we looked at the occurrence of sleep apnea in pregnancy, and they track together. Certainly, we have normal weight people who have sleep apnea, but among those who don't have a family history, it does track with obesity. So all of that said, this may be a problem to look at in pregnancy. And in fact, we found that depending on which population you're studying, that for young, healthy people, about 3 to 5% have sleep apnea in pregnancy, and it goes up as they get older and as they get heavier. And in the highest groups, we found up to 20 to 30%. So as a result of the studies that I've done throughout my career, we have found that if you have sleep apnea in pregnancy, you are twice as likely to develop preeclampsia. So preeclampsia is a high blood pressure condition in pregnancy that if you have it can result in preterm birth. It can result in certainly in strokes for the mothers. It can result in long-term complications for the mother. Now, we know if you have preeclampsia in pregnancy, there's also implications for the babies and that they could be too small. There's a higher risk of stillbirth. And also that even if you get through and everything is okay, in the postpartum, it's a longer recovery for the moms. They're more likely to have depression, more likely to have difficulty breastfeeding, and then certainly more likely to be readmitted to the hospital. We also found that if you have sleep apnea in pregnancy, you're twice as likely to develop diabetes in the pregnancy, what we call gestational diabetes. In about a third of people who have gestational diabetes, after they deliver, that diabetes doesn't go away. So there's some clear health implications there. There's also associated with it problems with the baby's growth where the baby can be too small, and there's an increased chance of preterm birth. So all of these studies kind of validated that if you have sleep apnea, that we can see some common complications of pregnancy. But I asked the question, could there be something more? Because there was one patient who, in my studies, had sleep apnea, and while she was having her C-section, she went into cardiac arrest on the operating room table. She survived, but we found that she had a pulmonary embolism. And when we looked at a database of over 50 million women who had had their deliveries, we found, in fact, that if you have sleep apnea, you are more likely to have a C-section, you're more likely to have diabetes, like I said, more likely to have hypertension, but also you were more likely to develop a pulmonary embolism, more likely to develop cardiomyopathy, and there was a higher rate of in-hospital death. And we saw that regardless of whether you had obesity with this sleep apnea or not. So that kind of answered the question where some people said, oh, this is, sleep apnea is not a big deal, it's all just the obesity. We were able to answer the question of whether it was something else. Since that time, and what I'm showing here are data from my publications, but since that time, there have been a couple more publications that replicated what we did and found the same thing. So from our perspective, it's clear if you have sleep apnea and you have a pregnancy, there's more risks to you for both mom and baby. But here's the challenge. Right now, we don't have a good screening test. The screening test that they use for sleep apnea outside of pregnancy, the symptoms mirror a lot of the pregnancy symptoms, right? So that can be a challenge for people getting testing. And we know that there's a shortage of sleep medicine physicians that makes it harder to get tested. But even when you get patients in for testing, there's a lot of barriers to getting diagnosed and treated. There's a lot of stigma related to it. When I first started studying this, probably the people who benefited the most were people in the audience because they would go home and tell their partners, I think you have sleep apnea because you've been waking me up with your snoring for years. But they struggled to get their partners tested. But we had a recent victory where a good friend of mine said after years of hearing my talks, she kept harassing her husband and he finally did get tested and has sleep apnea. But there's also competing priorities, right? Patients have families, they're busy, and so it's hard for them to put themselves first and to go get tested and treated, and then certainly there's the insurance costs. But all of this, with all of this, let's say they don't get treated in pregnancy. Well, we know long-term that if you don't treat the sleep apnea, they're more likely to develop high blood pressure if they don't have it already, more likely to develop diabetes and heart disease. And then they go into the next pregnancy, higher risk. So it sort of plays into contributing to more morbidity, both in pregnancy and the postpartum period, and more morbidity across their lifespan. So I started off studying sleep, but it highlighted to me that you can't study sleep by itself without the context of what it means in the broader sense of things. This figure is data that was published that looks at when people are having children. Okay, so one of the things that we knew is you think back then, growing up, what was I taught were the dangers? Forest fires, teen pregnancy, and getting trapped in sand, sinking sand, right? Right. We made those to be major things, right? Thankfully, I've never had to stop, drop, and roll. I'm not worried about sinking sand. But teen pregnancy, we're learning that maybe, not that we were wrong, but, the push away from teen pregnancy, we now have something different where people are waiting longer and longer before they have their first child. So they're having their first child later in life, they're having fewer children, and they're narrowing the time span between their children. And we're seeing the health effects of that. So we are seeing more complexity in pregnancy because the population is older. They're more likely to already have their high blood pressure or are close to getting the high blood pressure that is running in their families, so there's more complications in their pregnancy. So that's what this figure is showing, that if you look at that bottom line, that the black bar, those are the individuals who are age 40 to 44 having their first child, and you see that's going up over time. And certainly the gray line, the 15 to 19-year-olds, it dropped because that's what we advocated for, that teen pregnancy was not a good thing, and that dropped. So I think we still agree that there are worse outcomes with teen pregnancy, but that probably we probably need something a little bit more in the middle, where we have to recognize that to not underestimate the morbidity with having children when you're older. So depending on who you are, you have different needs. You can have different outcomes, and we have to be cognizant of that. We have to be cognizant that there is disparity, that when you look at the burden of pregnancy, that not everyone is equal in terms of their outcome, that there's a disparity in morbidity and mortality, and that it has been persistent over time. This figure looks at maternal mortality ratio. Dark purple are Black women, and you can see that the maternal mortality has outpaced the other groups. The pale purple are the American Indian Alaska Native population. They also have really higher rates of pregnancy-related mortality. And so they do need something a little bit different. So we can't ignore not just race, but then also their age. This is a very busy figure. If you take any given box, the bottom of the box, they're talking about age, and then what happens in each of those conditions based on age and pregnancy outcomes. So whether you're talking about C-section or late preterm birth, the older you are, the higher the risk is of those conditions. And so all of this is not to say you shouldn't have children at age 40 or 45, but that we have to be cognizant of the risks related to it. And let's not forget about the burden for patients who live in rural areas, something very relevant to the state of Virginia. We have a growing shortage of prenatal care. Fewer than half of all rural counties have practicing obstetricians. There's worsening morbidity, that you're 3 to 4 times more likely to have a pregnancy-related death, and higher rates of infant mortality. There's poor access to care postpartum. And we know that Medicaid pays for at least half of all rural births, in some regions more. And we have more and more hospitals that are closing, creating what we call maternity care deserts. So all of that contributes into the health of our populations, but also that 70% of the maternal deaths are preventable if we have the right resources. So this is a picture from March of Dimes that shows the maternity care deserts in Virginia. Bright red are the maternity care deserts where there are shortages. So not insignificant, and really plays into the things that we need to think of as we try to improve the health of our Virginians. And the inequities play into each other, right? So we know that there are inequities and unequal distribution of resources across the state and truly across the country, depending on neighborhoods and cities. There are differences in health insurance, access to the right care. So, you know, if you have a high-risk condition, it's not enough for you to locally have a midwife because that's not the right care for someone who has a complex condition. So to me, that's also something you need to consider when you're talking about maternity care deserts. But then also there can be poor quality care. Some regions are harder to get healthcare professionals, and the turnover is higher. And so that plays into the quality of care that the patients get there. And there are some clear scientific papers that have shown that certain proportions of racial and ethnic disparity lie in the quality of care, where people are getting their care from hospitals that have lower likelihood of meeting quality metrics. So again, it gives the perception that you have access, but you don't have access to good care, and that makes a difference in your outcome. So other than the maternity care deserts, we know that in Virginia there's also there's a deficit of primary care physicians. And so if you look, all those areas in dark blue are all areas that are deficient in primary care physicians. That's a lot of Virginia. And so let's say we get through the pregnancy and you do fine, but then you have a health condition that in theory, if you had hypertension in pregnancy, if you had diabetes in pregnancy, if you gave preterm birth, all of those predispose you to earlier onset of heart disease. And so you should be lined up with a primary care doctor to help assure improved health. But look, you're facing a struggle because most of Virginia has a shortage of primary care physicians. When you look at the maternal mortality data, On the screen, I lay out the statistics that have been reported. 19% of the maternal deaths between 2019 to 2023 in Virginia were due to indirect cardiovascular causes. So again, those people who would benefit from seeing a primary care doctor, from getting their health optimized, certainly before pregnancy and after pregnancy. 7% of the deaths were due to hypertension in pregnancy. So we have opportunities here in Virginia. So what are the things that we should consider, in my opinion? One of them is to make sure that we have good data, making sure that we continue to capture maternal mortality cases, to make sure that the definitions that are being used are standard definitions by the health community and not defined, by other parameters, so that then healthcare professionals understand what those numbers mean. And we have to make sure that the reviews are factual and that there is equity in the review process so that we're reaching data from all the parts of Virginia. The other piece is making sure that our patients have access to critical services, and that includes supporting reproductive health care, which is so important, especially for the patients who, like I said, remember, women are waiting until they are older. They're more likely to have complex conditions. Obstetricians are really, we've had to sort of revamp how we provide obstetric care because the volume of complexity in obstetrics has gone up. And so we're trying to respond to that, but we also need the help of having access to things like the right transition of care after pregnancy so that the patients can get to the right care. I put the example of postpartum Medicaid, which as an obstetrician, I was shocked that so many states did extend Medicaid in the postpartum. And we looked at data immediately before this. I was in Florida. We looked at data at our institution after implementing postpartum Medicaid, and we found a substantial reduction in the number of postpartum patients who went to the emergency room within the 1 year after giving birth. And they increased their visits to primary care physicians. So they were transitioning their concerns to the right place, which is getting that preventive care before it turned into an emergency. We need more data like that to show us the impact of programs like that, to demonstrate that they do in the end save lives and save money. So I think that's an important policy consideration. We need to support the hospitals so that we have fewer maternity care deserts. And then look into supporting novel partnerships that may include public and private partnerships. I would like to advocate that the Virginia medical schools actually form a quality network. We are poised to work together to really look at some of the major issues that impact health of Virginians, and that we should be able to work together and pool our strengths to come up with some solutions. And then, of course, continuing to support innovative strategies so that our patients in rural areas can get access to the innovative things that we are doing, within the major cities and the larger academic health centers. And that includes things like telehealth and AI screening. And lastly, I cannot overemphasize the need for investment in the healthcare workforce. We are short everywhere. We are short in all positions, whether it's nursing, physicians, midwives, et cetera. Despite this, we face the challenge that there are insufficient residency slots to maintain our health profession students, and so investment in those areas to incentivize people to remain in Virginia, to increase the number of residency slots are very important. Some states have helped by creating tax credits for healthcare groups that facilitate in training more students. All of those are potential areas for helping to improve and increase the number of people in the health workforce. And certainly we're looking at the new caps on loans for professional schools, which will surely impact the number of people who can train in the health professions, particularly individuals from low-income households who may not have the means to get the private loans. And so those are areas that certainly at EVMS we're looking at and trying to address for our students, but also across the state would benefit from it, that attention. And so with that, I would like to give time for any questions.
Thank you so much for that wonderful presentation. I will open up for the committee. One question I have is regarding going back to the beginning of your presentation about sleep apnea during pregnancy. And you mentioned sleep medicine being its own separate sort of body of work. So how are women screened during pregnancy? Is it with the OBGYN where we're going, pretty regularly? And how is that screening working?
So a lot of women will not see a primary care doctor, and so they will serve, their OB-GYN will serve as that. And so what we have found is most women report their symptoms to their obstetrician and or their midwife. And so we have worked with them to help them identify what are the symptoms of sleep apnea, so then they can refer those patients to get testing. The testing is currently is at-home testing, a device that you put on, but it starts with the questions of, do you snore frequently? Does your partner have to sleep in a different room? Are you falling asleep at inappropriate times, such as while you're driving at a red light, things like that? Those would be some of the typical symptoms.
Right. And then, so as part of I guess I would say your protocol is that like a standard to screen for the sleep apnea, or is it only patient driven?
So the standard that we recommend in my publications as guidelines from our society is that you should at least screen high-risk women. So those are women who already have high blood pressure or diabetes, or a BMI over 40, or heart disease. It's not clear that low-risk women would benefit from screening.
Got it. Thank you so much. And I'll open up the committee. I'm to be honest, I don't know how the Senate side works, so just raise your hand. Delegate Ken.
Thank you so much. I'm a fellow twin mom too, so I appreciate all your comments. I'm also in one of those maternal health deserts that you mentioned, because I'm in a very rural part of Virginia. I just wanted to know if you could expand off of what you said about telehealth being an opportunity. We're really focused so much on telehealth because I am in a rural area and we're 60 plus miles from hospitals. Right. How does that work given the uniqueness of kind of postpartum and care and what that needs to look like in terms of, really having a baby and not being able to do so in a rural community and having to travel? God bless you. How do you incorporate telehealth into that? And is there a policy mechanism that helps?
So what I have experience in doing is setting up telehealth practices for particular things. So for instance, we know that with the maternity care deserts, you're less likely to get access to high-risk pregnancy care. So setting up so that your local physician or midwife or nurse practitioner can go through a screening questionnaire with you that helps identify your health risks, and then we set you up with a telehealth appointment with that person who may not be there in your neighborhood. They may be an hour away, but they have the right expertise. So that's a program I'm used to setting up where we've had high uptake. It doesn't solve your need to then go to deliver at a hospital that's 60 minutes away. But what it can do is help identify early on if you have risk factors that helps get you to the right hospital, so that you're delivering at a hospital that has the right level acuity or the right level NICU. It also has decreased the time that people can get in for an appointment. On the workforce side, it helps the individuals who would prefer to do telehealth work or work part-time rather than completely falling out of the workforce itself. It gives them an avenue for them to continue work and stay in the workforce, and that they can do telehealth visits from their home. So I think it's a situation that can benefit both patients and the healthcare workforce that we have to continue supporting and investing in.
Thank you. We'll take, start from the end with shorter and come to Senator Perry.
Okay. Thank you, Dr. Lewis, for your presentation. It was very informative. I was wondering, in your experience, have you noticed any biases in treatment that may lead to the outcomes in your presentation when patients present their insurance? May it be Medicaid or corporate insurance?
Right. I think that part is well established, that particularly we know even outside of Virginia that some practices do not take Medicaid. And in fact, a lot of the studies, where people say, that people get insufficient prenatal care, what you find is that they have a delay in their prenatal care, mostly because they were trying to find someplace that took their insurance. So yes, there is a bias against that, against what type of insurance you have that may delay your care. And because of the reimbursement from Medicaid being so low, those practices that take Medicaid, have to see higher volumes, and they run on a narrower margin. That all of that impacts your care. It impacts how much time people spend with you. Some of those clinics try to staff them in a lower cost model. So it impacts who you have access to for your care. So really, from start to finish, there are impacts related to that.
Okay. And is there anything that you see where the new administration or legislators could improve access with improving policies or practices concerning the treatment and disparities that you just discussed?
I think, policies that continue to support really appropriate payment for maternity care services helps. One of the areas that we often cite is that the CRNA who does your epidural gets more for the pregnancy gets more for that one epidural than obstetricians get for the whole pregnancy, right? So I think the appropriate funding of prenatal care and postpartum care, as I said, the payment for or the extension of postpartum Medicaid also helps to increase access because they have coverage in that period of time. And I think policies to continue supporting telehealth, which was supposed to go away, that could be devastating to a lot of communities where there had been a lot of businesses set up around telehealth to provide access. Without coverage, those companies, some of them are going away, but some of them are saying, well, then we'll just go to cash only, which then goes back to, to only if you have enough money can you access these services.
Thank you. Senator Perry?
Thank you so much. First, I just want to say thank you for spending time with us here today. I know you have a million things going on. We're talking about shortages, and you come here to educate us, and I really appreciate your time. I have a couple different questions. I carried a bill about telehealth last session that passed, and it was geared towards specifically forensic nursing, but again, trying to address some of these rural healthcare deserts, getting some folks some help that they need. And I guess just from a fundamental level, outside of the funding, is there anything that you see that we need on a legislative policy level to make sure that telehealth is easy and accessible, that if it's my office, can I expand my telehealth so that I could help reach other people? Is that something that you see, or no, that's not really it? It's just mostly funding.
It's mostly funding because with COVID, what was nice was that a lot of the infrastructure came into play. For some practices, the cost of setting it up, because you need secure, HIPAA compliant platforms for you to do it, it just becomes a cost issue.
And Madam Chair, if I could ask another question. Yes. Okay. And I saw on your slide, you mentioned when your sleep apnea, one of the slides, you mentioned, quote, more risk for subsequent pregnancy. Are you suggesting that if I have sleep apnea and I make it through a pregnancy, because of my sleep apnea in a subsequent pregnancy, I would be at higher risk, or just it's higher risk because I have a subsequent pregnancy?
You would actually potentially be in a higher risk category because let's say you had sleep apnea with your first pregnancy, but you were perfectly fine otherwise. Because that sleep apnea goes untreated, you are more likely to develop high blood pressure in the subsequent years, diabetes, and if you're in a good position, we know going into the pregnancy you have hypertension or diabetes. But there's a lot of people who, in the interim, did not receive any care, and so we're only detecting it at the time that they're pregnant.
Madam Chair, if I could ask one more question.
Senator Perry.
And obviously, a number of people have sleep apnea who are not pregnant, right? And then obviously people. Senator Lucas says she's not pregnant. But you were talking about, I thought it was so interesting in your study when you were talking about the risk of the embolism, and I thought that's really, I think, really, really interesting. Do you know, just in terms of coverage, right? Sleep apnea seems to be a thing that's associated with a lot of health risks. Do you know if I were not pregnant, which I also am not pregnant, and I had sleep apnea, would I also be at risk for embolism, or is it because I'm okay?
Yes, you absolutely would be at risk for heart disease and pulmonary embolism. In fact, the reason I looked at those conditions was that there was clear data outside of pregnancy that showed increased risk of those conditions because of what the hypoxia does to your body. You know, I spared you guys the biochemistry slides, right? But it actually is pretty traumatic to your body, where there's more inflammation, there's more what we call oxidative stress, and it inflames your arteries so that it results in more heart disease, more cardiomyopathy, and more pulmonary embolism outside of pregnancy.
And so from a policy perspective, I'll just say sleep apnea is just a big thing for everyone, not just pregnant women, but for everyone in their health outcomes.
Absolutely, and certainly it's a public safety issue with commercial drivers and the high rate of it. In fact, I laugh about how when I was a band mom, and when my kid would go on trips, I would be physically screening the bus driver for sleep apnea because I know about the risks. So, you know, it is what it is.
Thank you so much.
Thank you so much. And Dr. Lewis, before you take a seat, I want to thank you so much. And I would love to entertain from this committee. This seems like, as Senator Perry said, a condition that is impacting us and also impacting pregnant women in a way that we just really haven't addressed. So I would entertain from this committee. We created a subcommittee, I think at last committee, about life experiences and challenges that we add this sleep apnea issue during pregnancy to that committee.
I'll make that motion.
I was going to make that motion too. Okay,
I'll second it.
And we have a question.
Yes.
So with the OBs and midwives, is everyone screening for this? Is this normal to screen for it, or is this something that we may need to start like raising awareness to and asking questions? Are you screening pregnant people for this?
Yes, our current recommendations are for high-risk patients. So particularly obstetricians who take care of high-risk women who have hypertension, diabetes, we do recommend screening them. And we also recommend that if they have new onset in the pregnancy, you know, heart disease such as cardiomyopathy or an arrhythmia, it's very atypical for a young, healthy person to have those conditions. It can be a marker of sleep apnea, and we recommend screening.
Thank you. And I think it's been moved and properly second that we add sleep apnea during pregnancy to our life experiences work group. All those in favor shall say aye. Aye. Any opposed? All right, we will add it to our subcommittee on life experiences, and we will keep a copy of your recommendations and be sure they are included in those conversations.
Thank you, and I thank the commission for this work. I will say one of my frustrations over my career had been an insufficient attention to the health of women, and so I thank you for this work.
You are preaching to the choir. And we are so grateful to you for bringing this. That is the reason this commission was created, to address those concerns on women's health that aren't getting the attention they need. And next up, we have a few presentations, and we are getting a little tight on time, so I'll ask our presenters to be mindful of that and to also know that we'll be sharing the slides as well, but want to make sure we have time for any questions and follow-up from the committee. First up, we have Christina Benton, Amanda Cuidado, did I get that right? And Jackie Knight, presenting data on breast and cervical cancer screening programs.
All right. Good afternoon. Thank you again for having us all here today. My name is Jackie Knight-Wilt. I am a cancer epidemiologist and evaluator from within VDH. For today, what we're going to do is have an overview for you all of what are the cancer programs that we house within the Virginia Department of Health. I'm going to lay the land then of what does our current breast and cervical cancer data look like for the state of Virginia. Then Christina's going to follow. She's going to review the Every Woman's Life screening program. Amanda will then come up and talk about our comprehensive cancer control program that we have at VDH, and then we'll do some resources and we'll have time for questions as well. So overall, at the Virginia Department of Health, we have a couple of different cancer-related programs. We have 4 that are CDC funded. Myself am housed within the Virginia Cancer Registry. The registry is mandated by the Virginia Code. This means that any new cancer case that is diagnosed or gets their first round of treatment is required to be reported to the Virginia Cancer Registry. So we are really the central entity within the state of our cancer data surveillance for incidents, trends, and disparities that we observe. We also have the Every Woman's Life program. This is what provides free breast and cervical screening to low-income and uninsured Virginians. We have the Virginia Comprehensive Cancer Control Program. This is where we collaborate with the state cancer coalition called the Cancer Action Coalition for Virginia, and they develop together with us a Virginia cancer plan that we work on. And then finally, we have the colorectal cancer screening program, which partners with FQHCs throughout the state in order to increase our colorectal cancer screening rates. So as I said, myself as an epidemiologist, I'm housed within the Virginia Cancer Registry. We're the primary data source for cancer in the state of Virginia. As I said, we're mandated with Virginia Code, so we receive data directly from healthcare providers. We have from death certificates, and we also have an interstate data exchange with surrounding states as well when Virginians are getting diagnosed or receiving treatment outside of the state. All of that data comes into us, and just for reference, it's about 66,000 cases per year that come to us. Our staff then work on consolidating those because sometimes you'll have multiple treatments being reported for an individual, and it gets consolidated down to about 46,000 per year. That consolidation process is why when you look at our most recent data, it tends to be a 2 to 3 year lag because it takes time to clean that up. What stage were they diagnosed at? What type of treatment did they receive? So the data I'm going to present to you today, our incidence data is 2018 to 2022. Mortality data is 2019 to 2023. As I mentioned, we receive CDC funding for the Virginia Cancer Registry. Here you can see where we have our CDC funding, our federal level funding. We also, it helps fund some of our IT, our servers, because we have a great deal of data. And then we do see state general funds from the bucket of funds that are allocated to the Office of Family Health Services at VDH. So the lay of the land of what cancer for breast and cervical look like among women here in the Commonwealth. The top 5 cancers experienced for incidence among females include breast, lung, colorectal, uterine, and melanoma. Again, in mortality, you'll see lung, breast, colorectal, pancreas, and ovarian. Outside of these is cervical, which had an incidence rate, it's even outside of the top 10 for females. Just for reference, the incidence rate is about 6.7 per 100,000 females. Mortality rate is 1.8 per 100,000 females in the state of Virginia. Among these, you'll see breast, lung, and colorectal. We have well-known screening guidelines for these to detect at an earlier stage for prevention so that we can detect earlier and have better treatment outcomes. Additionally, cervical also has screening guidelines that we have in place, and cervical is marginally preventable with HPV vaccination. So for today specifically, we're going to talk about breast and cervical since we have screening programs for those, and they are female-specific cancers. When we look at 10-year trends for breast cancer in the state of Virginia, we've remained pretty steady. You see the little blip in 2020, that was access to screening that happened during the COVID pandemic. Less people were getting in for their screenings, but then we have recovered since then to pre-pandemic rates that we were seeing. You'll see similar with cervical, it's mostly steady. It looks a little more fluctuating, but because, again, those incidence rates were so much smaller, it's a much smaller sample size, so a little more sensitive to fluctuation that happens over the years for them. When we look at geographical distribution of where breast cancer is happening in the state of Virginia, this is one in your top left corner. This is our incidence. You're seeing higher incidence in the central region of Virginia. But then when we look at our late stage diagnosis, which is on the bottom, and mortality, they're reflective of each other. We're seeing higher rates of being diagnosed at a late stage, which means it's more advanced stage of cancer requiring more invasive treatment for health outcomes. And we're seeing the higher late stage diagnosis as well as mortality in that southwestern and south central regions in the state. For cervical, you'll notice here we present the data as health district instead of locality. The reason being there's such fewer cases of cervical cancer, and our standards are if there is less than 16 cases per locality, we suppress that data in order for HIPAA compliance to protect that individual's privacy so they can never be identified. So I'm presenting cervical data to you today at health district level because there are such fewer numbers at locality level. Here you will see we have higher incidence in the southern part of the state. And then when you get to mortality, you see our largest portion of mortality is happening in the southwestern corridor of the state. And then we also have much later stage diagnosis happening marginally across the state of Virginia. And you'll see that here shortly as well when I present by stage diagnosis.
Could you go back one slide? The bottom, could you give the bottom, and it's probably because don't have on my right glasses. The bottom, that Northern Virginia shaded blue area, could you explain that?
The dark blue area?
Yes.
So the dark blue area indicates that it's a higher percentage of people that are diagnosed at late stage.
Okay, thank you.
So then when we look at incidence of cancer by race and ethnicity, we see that with breast cancer, we have similar rates among white non-Hispanic and black non-Hispanic in the state, with Hispanic having lower rates. And then for cervical, we have similar rates that are happening for white non-Hispanic, black non-Hispanic, and Hispanic. We start seeing some differences when we look at late-stage diagnosis by race ethnicity. Again, remember, late-stage diagnosis is a more advanced stage of the cancer requiring more invasive treatment for health outcomes. Here we see that black females, black non-Hispanic females, and Hispanic females have a higher percentage that are being diagnosed at late stage compared to white females. When we look at cervical cancer, we see we have similar rates, but it is much higher. One reason we have higher rates of late-stage diagnosis for cervical cancer is it's very slow growing. It takes about so it probably has been longer since a person was screened for the cervical cancer. It's giving it time to have growth and development. When we look at mortality, here again is where we see some differences, particularly when we look at the breast cancer mortality between white non-Hispanic females and black non-Hispanic females. When I ran a mortality rate ratio, this is a significant difference that we're seeing. Black females are dying from breast cancer at a rate of 1.37 times higher than those of white females. So this is a disparity that we are observing in the state of Virginia. And then you'll see that cervical doesn't have very big differences across race groups as pertain to mortality. When I broke it down, looking at diagnosis by insurance type, at the time the individual was diagnosed, for breast cancer, we see largely broken up between private insurance and Medicare. When we look at cervical cancer, we're seeing 40% that private insurance, and then we're seeing a split really between Medicare and Medicaid at this level. One thing to keep in mind is that breast cancer is more commonly diagnosed at a later age, and so we are seeing more people that are enrolled in Medicare, whereas cervical cancer is often has an average age about 10 years younger. So we have individuals who are Medicaid at that time. When I looked at the All Payers Claim database that we have, All Payers Claim database covers about 75% of Virginians that report their claims for Medicaid, Medicare, federal funded insurance programs all submit claims to All Payers Claim database. For those who were eligible for breast cancer screening in 2024, 67.8% did complete a breast cancer screening. For those who were eligible for cervical cancer screening, 53.2% completed their screening.
Madam Chair.
Yes, we have if you don't mind, a question from Senator Perry.
Yeah.
Why is that? Why are more people getting screened for breast cancer than for cervical cancer?
A lot can happen with guidelines or with this group. The way that All Payers Claims Database measures it, their metric is developed by HEDIS, which is the practice of what are the guidelines. So breast cancer is for those age 50 to 74 that are being captured. Cervical is age 21 up through 65. A lot of times what we see with cervical is with it ending at age 65, people will get diagnosed at a later age because they're not keeping up with screenings with some of the guidelines that we see.
So we should expand our screening guidelines, is what you're saying, to later in life.
I would also just add that.
If you could come to the microphone so those online can hear.
So cervical cancer screening is also more invasive, for lack of a better word, and so women tend to be more apprehensive about going in and getting cervical cancer screening.
But the vast majority of people that we're seeing who aren't getting it are people later in life, or no?
No, it's across the board because then again, this is capturing age 21 through 65. So, and again, when you're talking about someone who's 20, I worked in college health before here, 21 or so, sometimes there's stigma around, I'm not being sexually active, so I don't need to get a pap test and such, whereas the pap test is what's done for the cervical cancer screening.
Okay. That sounds also like an education point, but thank you.
Thank you.
Another source that we use to talk about screening rates is the Behavioral Risk Factor Surveillance Survey. This is a self-reported survey, whereas All Payers Claim Database are claims that are being mandated reported. With our Behavioral Risk Factor Surveillance Survey results that we saw, when we broke it down by insurance type, we see that breast cancer screening, there's clearly a difference with lower adherence to breast cancer screening for those who are Medicaid or uninsured, whereas we have much higher compliance among cervical cancer screening individuals.
I'm so sorry. Could we go back to one point about the cervical cancer screening?
Mm-hmm.
And you may know this, and no pressure if we can look it up, but I believe the guidelines nationally changed a few years ago.
Mm-hmm.
And so from annual to, I think, every 3 years.
Every 3 years. And then it also depends on your age, and it depends on what results you received at that time if you got abnormal ones. So they really fluctuate per individual.
And one thing I would love for this commission to consider is with that, if we would look at the insurance coverage for those who would like to continue receiving annual screenings outside of those guidelines. Mm-hmm. So just something I just wanted to flag for us to keep in conversation.
Yep.
Thank you.
Yes, of course. So this is actually where I'll have a great transition to Christina's going to come up and talk about the Every Woman's Life, because again, here we see such a difference in those who are Medicaid or uninsured with getting their screenings completed.
Thank you. All right, so my name's Christina Benton. I oversee the Every Woman's Life program, as well as the Comp Cancer program and the colorectal program that Jackie had mentioned. So our Every Woman's Life program is our breast and cervical screening program for the state. It's part of a larger national program funded by the CDC that has been around since 1991 nationally. In Virginia, it's been around since 1997. All of the states, DC, a number of territories, and tribal organizations are all funded through this national program. So the mission of Every Woman's Life, or EWL, is to provide high-quality breast and cervical cancer screening and follow-up services or diagnostics to low-income uninsured women in the most cost-efficient manner. Currently in Virginia, we have over 500 providers that participate in the program. The large triangles that you see here, those are 27 providers that we contract with directly. They, in turn, work with a network of providers in their community to ensure that women receive all of the clinical care that they may need to get to a final diagnosis. So those are all the smaller dots. To be eligible for the program, one needs to be a Virginia resident, be uninsured, at or below 250% of the federal poverty level, and be 18 to 64 years old. Those who are 18 to 39, they need to be either high risk for breast or cervical cancer, or they need to be symptomatic in need of workup. The services that are covered through the program are a clinical breast exam, a mammogram, a pelvic exam, the Pap and HPV test that was mentioned earlier, any diagnostics, ultrasounds, all the different types of breast biopsies one may need, as well as colpos, which are for cervical abnormality. Gosh, I cannot talk. Patient navigation is also covered by the program to help women address any barriers to accessing care and to help navigate the healthcare system. So what happens if someone is diagnosed through the program? The Breast and Cervical Cancer Prevention Treatment Act was passed by Congress in 2000, and it allows states to provide full Medicaid coverage for U.S. citizens, as well as some legal residents who are diagnosed through the program. In Virginia, for someone to be eligible for the BCCPTA, they have to be a Virginia resident, they have to be 18 to 64. The key pieces are they have to have been screened or diagnosed by an EWL provider who was participating in the program at the time, and they need to be in active treatment. So that means radiation, chemo, surgery, hormone therapy, whatever it may be. So I mentioned that the program started in '97. Since then, it's served over 76,000 women. We've provided over 150,000 breast screenings, have diagnosed over 2,500 breast cancers, have done more than 66,000 cervical cancer screenings, and diagnosed more than 1,300 cervical precancers or cancers. According to 2022 U.S. Census data, there are 20,472 Virginia women who are 40 to 64, so just a portion of that total population we can serve, that are eligible for the program given their household income and their insurance status. You can see from the chart on the right that on any given year, the program serves between 6,000 and 7,000 women. We had quite an impact, as you can see, from COVID from 2020 to 2022, but have recovered from that. And in the current fiscal year, 2026, are on track to serve over 7,100 women in the program. Here's some information for you about how our funding is structured. Most of our funding does come from the CDC. We were awarded just over $3.3 million for fiscal year 26. We also have some funding in terms of general funds that we get from the bucket of funds that Jackie mentioned that our office receives annually. The one thing I want to point out with this is that of the federal dollars that we receive, 83% of them go out into the community to cover the clinical costs for the screenings and diagnostics that women receive through the program. And then for those who are interested in learning more about who your local provider may be for your community, on our website, we have an interactive map where you can click on the locality and get your provider's name and contact information. And then we also have a toll-free line and a email inbox that folks can use to reach out. And so I'll turn it over to Amanda so that she can talk a little bit about our Comp Cancer program and our coalition.
Good afternoon. Thank you for the opportunity this afternoon. My name is Amanda Corrado. I am the Comprehensive Cancer Control Coordinator for the Virginia Department of Health. As a brief overview, some of this has been touched on by Christina and Jackie. For about the past 25 years, we have received repetitive 5-year funding cycles from the CDC. Ultimately, that served to maintain and support the state's coalition. In Virginia, that is the Cancer Action Coalition of Virginia. I'll go more into them on the next slide, but CACV is how we'll refer as a shorthand. With collaboration with CACV, we develop the Virginia Cancer Plan every 5 years. We are currently in the 2023 to 2027 iteration of Virginia's cancer plan, and ultimately, this collaboration and this plan serves to develop, implement, and strengthen programming for evidence-based interventions to address cancer across the cancer continuum for all types of cancers and evaluate those efforts. CACV, Virginia State Cancer Coalition, serves as a 501c3 nonprofit. They were founded in 1998. To essentially reduce the burden of cancer. They have representation from all sort of sectors, from cancer centers, all the way through survivors. The Virginia Cancer Plan, again, we're currently in the 2023 to 2027 iteration. This is a comprehensive, living, collaborative document that is 66 pages in total. There are 18 overarching goals and over 100 data-driven objectives that really outline the work to be done for multiple different types of cancers and from prevention all the way through survivorship and palliative care. This comprehensive plan is too large for one person or organization to do alone. This really is a opportunity to collaborate across many sectors to address the burden of cancer in Virginia. I won't read all of these specifically, but these are the 5 key areas from prevention, early detection, diagnosis and cancer-directed therapy, survivorship, and then Virginia is unique in that it has a pediatric, adolescent, and young adult cancers. There are a few other states across the nation that have this, but Virginia was one of the first to put a pediatric AYA objectives within their cancer plan. The Cancer Action Coalition of Virginia has really broken down into a number of implementation teams, we call them. I have bolded the 2 that are really relevant to our conversation today, but you can read through the bullets for the other groups that some of them focus on specific cancers, some of them focus upon between our Navigator Network and our survivorship across the continuum. So the Virginia Breast Cancer Roundtable, really what they've been working on lately is assessing mobile mammography coverage in Virginia. The map on the left side is our public-facing map that highlights where mobile mammography services are currently available in Virginia, as indicated by the orange localities, and then the gray localities identify areas of growth, areas of opportunity to increase mobile mammography coverage. This VBCRT has a subset called the Mobile Mammography Work Group that really has come together with representation across Virginia sectors and the mobile leads of all those units. I believe it's 7 to 9 that are represented.
9 mobile units.
Yes, 9 mobile units or 9 health systems that deploy mobile units to the covered localities. So really starting that conversation of how we can leverage our resources to expand that mobile mammography coverage across the state, because there are quite a few areas that are not covered through mobile MAM services. And then I've pulled out the cancer plan objectives for you to review that address the burden of breast cancer or opportunities to address breast cancer throughout Virginia. Another one of the implementation teams is the Virginia HPV Immunization Task Force. About 91% of cervical cancers are caused by human papillomavirus, or HPV. So really an opportunity to mobilize persons and sectors that are focused on HPV immunization as a really powerful tool to prevent cervical cancer in women. Again, I pulled the cancer plan objectives, really that highlight focuses on improving HPV vaccination in eligible populations based on age range and what the guidelines currently state. And really our VHIT group has focused on interventions with FQHCs to increase quality improvement, to be able to improve those vaccination rates, and a high focus on using dental care providers. CACV has worked with Virginia's dental schools and dental hygiene programs to implement HPV-related education into their curriculums. They're really trying to train providers to be able to integrate HPV education within their dental clinics. Also, because even though it's 91% of cervical cancers, it's also about 70% of oropharyngeal cancer. So there is a strong linkage and opportunity to encourage our dental providers in HPV immunization. You'll have access to the website and email. If you want to email our coalition, I really encourage you to check out the website. And then similar to Christina's breakdown of the EWL funding, just an opportunity to preview how our comprehensive cancer control program is funded here in Virginia. The next slide has linked resources that will be available for you to access. And then lastly, our contact information. That's all I have for today.
Thank you so much. Thank you all. I have one question, and then I want to finish the next presentation, and then we can ask questions for the entire group. As you all were here presenting this amazing information, I was doing just a little quick search on VDH. How do people find out about the work that you're doing? Because it seems to be hidden in the VDH sort of landscape?
So I can't speak to the website,
Okay.
but we will take that feedback back.
Okay, thank you. Please
Yes,
do.
yes. Yeah, I mean, in terms of our Every Woman's Life program, we work with a lot of different community-based organizations to get the information out, and then the providers that we work with do a lot of community outreach to identify women who are eligible for the program. But we share your feedback on the website because we also struggle at times, so we will take that back, yes.
I certainly understand, because I imagine, we all know a cancer diagnosis is one of the most heartbreaking things, and having a resource like this and knowing where to find would be extremely helpful. So I want to, it's more for me than for you to flag for us that this is something we could maybe support you all in doing.
No, that's great feedback, thank you.
Thank you. And next up, we will have Krista Miller and Aaron Stetchliger. I'm bad with names today, but I want to get it right. Names matter, so say it for me.
Aaron Stagletter.
Just the way it's spelled. Aaron, you have the floor.
Thank you so much. As you said, my name is Aaron Stagletter. I'm the Director of Programs for Virginia Breast Cancer Foundation. I'm going to be talking a little bit about our programmatic work and education work at VBCF, and then I'm going to hand it over to my colleague Kirsta Millar, who's our Director of Policy, which will talk a little bit more about the policy work we're trying to do. So Virginia Breast Cancer Foundation's mission is to empower Virginians impacted by breast cancer through access, advocacy, education, and community action. We were founded in 1991 by a group of 5 women who met at a breast cancer support group and were frustrated that they were receiving the same treatment for breast cancer that their mothers had received decades before. So they gathered up a bunch of people, hosted a Mother's Day rally here at the state capitol, and sort of the rest is history. Their focus on educating women and changing policies to support people who are impacted by breast cancer is the mission that we've retained for almost 35 years. I also want to mention that vast majority of our funding is through private donors, though we do get the benefit of the pink ribbon license plate through the DMV. Thankful for your support throughout the years in order for us to have that monetary support. We have a lot of educational resources available for free on our website. We have our free newly diagnosed packets that we send out across the state, free breast health materials that are available in English and Spanish to anyone who requests them through our website. We attended 26 educational events last month alone across the state due to it being Breast Cancer Awareness Month. And we really are available year-round to talk to communities and individuals about breast cancer so that folks have the right information at the right time so that they can get to the doctor when they need to. I want to talk a little bit about the issues that we're seeing in our community. I speak a lot to people across the state. I field a lot of phone calls from folks, and I just want to walk you through kind of an experience that we're hearing a lot more about. So think about a woman in her mid-40s who has shift work, that's her job, and she's trying to get a mammogram. What are the things that she has to navigate? So first, she has to make the appointment. If she has health insurance, that makes it a little bit easier for her to make that appointment. She might potentially have to miss hours at work, likely not covered through paid time off. So she's taking a cut in what she's expected to be paid for that next paycheck. She might be trying to navigate childcare or potentially other elder care if she's caring for family members at home. And then there's the transportation costs. So she understands that a mammogram is important to her health. She has it provided for no cost to her through her health insurance. So she's like, okay, I'm going to go ahead and do this. And then she gets a call back that she had abnormal results. And now she has to go through the whole process again, maybe a couple different times to schedule diagnostic, mammogram, biopsy, potentially ultrasounds. The list goes on. And also, currently, she might be quoted the price of $500, $1,000 for those tests. And oh, by the way, we want to see you in the next 2 weeks. It's very difficult to come up with that amount of money quickly. I do want to mention, thankfully, you all helped us to pass a bill so that landscape will change for women next year, and Kirsta will talk a little bit more about that. However, we're also hearing more from women who are uninsured. And they don't qualify for the Every Woman's Life program because they make too much money. I have two cases of women who are in their 50s and decided to forego purchasing health insurance on the marketplace this year because they're generally healthy. They are trying to put away a little bit of money for retirement because they know that their working years are getting shorter. And then they save up for the health expenses that they're anticipating. So these are women who knew they wanted to get a mammogram, so they saved up to do that. But then they get the call that they had an abnormal result, and now they're scrambling to figure out how they're going to pay for the diagnostics. One of these women that I'm referring to, she was diagnosed with breast cancer. So now she's trying to figure out how she could possibly pay for treatment and negotiating with hospital charity care programs to get the care that she needs. We also know that cancer is very expensive, so potentially these women are going to be in debt for the rest of their lives due to this decision, like, I can't afford $500 a month for health insurance. I'm healthy. I'm probably going to be fine. Let's roll the dice. And then that can be very costly. But again, thankfully, we're going to have some benefits for folks who do have health insurance starting next year. I also want to talk about there's still a lack of knowledge around breast cancer. I'm still educating women about age 40 is the time that women of average risk should start getting annual mammograms. There's a lot of conversation too about, well, is a mammogram really worth it? Can I just get an ultrasound instead? And educating women about, yes, the potential discomfort of a mammogram is worth it for the accuracy that you get in the testing over an ultrasound alone or other potential testing methods. There's also a lack of awareness around clinical trials. We are so lucky to be in a state that has 2 NCI-designated comprehensive cancer centers at VCU and UVA. And there's a whole host of other cancer centers that are providing clinical trials, but people don't know about it. This disparity really is more pronounced in Black women and Black cancer patients in general, because they're less likely to be offered the opportunity to participate in a clinical trial, because some medical providers assume that they're going to say no, so they don't even ask. I'll also mention that there's a lack of awareness around genetic testing. So genetic mutations only account for about 5 or 10% of breast cancer cases. However, the likelihood of having breast cancer, if you have a genetic mutation, can be as high as 80% of your lifetime. So this really would benefit patients to be aware of what their genetic testing options are. However, health insurance will cover the costs of BRCA, so the most common type of breast cancer mutation, BRCA, only if you're at high risk and things like that, but they're not going to cover other potential genetic mutations. So there's a lack of awareness of other genetic mutations outside of BRCA, and there's only potentially insurance coverage for BRCA testing. I'll also mention that there's still a lot of fear when it comes to conversations around breast cancer. When I am out in the community, I'll tell my interns this all the time. Sometimes when you're sitting at a table at a health fair, you're gonna get people coming up to you telling you their whole life story, telling you about their breast cancer experience or their loved one's breast cancer experience and how they benefited from resources or how they didn't. And then you have some people who walk a farther path away from the table. I've had people walk to my table, see all of the pink, and start to tear up. There is still a lot of fear around the diagnosis of breast cancer, that a diagnosis of breast cancer automatically means death, which it does not anymore. And this is something that we are going to have to contend with for years to come. However, what we have found is that if we address other barriers to testing, screening, access to care, women are going to be more likely to face their fear of getting a mammogram, potentially being uncomfortable, going through the diagnostic process, because they know they have help. And that's why we have established our diagnostic fund. So this is a program we established in 2022. We have since served over 1,000 Virginians and provided, we've covered the cost of diagnostic testing for patients who are underinsured. So they have health insurance, but they just can't come up with the copay, coinsurance in order to cover the cost of these diagnostic tests. We conceived this program to really be a complement to Every Woman's Life, because Every Woman's Life covers folks who are uninsured. So anyone who was coming up to them who was really trying to rub two pennies together in order to get funding to cover these costs, EWL has to say, I'm sorry, we can't help you because you have health insurance. That's where we come in and say, we can help you. And this is a benefit for our partners who are both EWL providers as well as connected with us, because they get to tell a patient, you don't qualify for this, but you do qualify for this other program. We don't like telling patients that there's nothing that we can do to help you. Let's see. Even with this new law, the new diagnostic imaging law, there will be a need for this program. Currently, we cover everything from the diagnostic imaging through biopsy and pathology. The new law does not cover biopsy and pathology, so we still will be assisting underinsured women with these costs. We had a lot of conversations this summer with our partners when there was that delay in EWL funding as to how on earth we were going to try to cover this gap that we were potentially facing with even a long pause in EWL coverage. We had conversations with our partners who are also EWL providers, and they were thankful for the availability of our program so that they didn't have to pause screenings for their patients during the confusion. We also have nowhere near, as you can see, we have nowhere near the reach of Every Woman's Life and nowhere near the budget. So we were trying to figure out how we could fill this gap, and it just honestly was not going to happen. We work best with Every Woman's Life, like two puzzle pieces fitting together. We definitely can't do it alone, and EWL makes the process so much smoother so we can have a more comprehensive safety net for Virginians who are struggling with their healthcare costs. And now I'm going to pass it over to Kirsten Millar.
Hi, everyone. It's wonderful to see you, and I will be quick so we can get to questions and answers. There's been great information shared. I wanted to just touch upon some of the work that VBCF does on the advocacy policy space. Hopefully, many of you have seen our advocates in your offices. We host a annual state advocacy day for breast cancer, and come down every year when we can. We took a break during COVID times, but we've been back in action last couple years. So we train breast cancer volunteer advocates who are survivors and thrivers to be advocates on behalf of breast cancer policies. And just to give you some examples of some of the things that we've worked on, in Virginia, we ended drive-through mastectomies. Now you have to have at least a 48-hour hospital stay. It's kind of hard to imagine that you could get in and out the door quicker than that. We were also the third state in the nation to pass a breast density notification law. You may have heard that last year there's a national notification law that so that it's uniform across the states about what you have to get after your mammogram in terms of your breast density, but we are proud that we were one of the first to at least have some of that notification for women in Virginia. I won't go through all of these, but you know, one of the other things that Erin has touched upon is just how expensive it is to have cancer, and breast cancer in particular. National data shows that about 50% of cancer patients and survivors have medical debt related to their cancer treatment. So we began to work on some bills that have been through the General Assembly the last two sessions around medical debt reform to end having medical debt reported on your credit score. And then this year, capping interest rates and late fees on medical debt at 3% a year, and putting
putting a prohibition on putting liens on houses and personal property for medical debt. So that just gives you an idea of some of the broader things we've worked on. And then this year, we're very excited that thanks to Senator Perry and Delegate Simons, who are on your commission, that we're the chief co-patrons of our new no-cost diagnostic and supplemental breast imaging law that passed, and I'll talk about that in a little more detail in a second. But I also wanted to highlight that we also go up to Congress every year. And one of the things that we're most proud of is that we advocate on behalf of the Department of Defense Breast Cancer Research Program. And that's been since 1993. We've been advocating for money for research dollars to come back to Virginia, to places like UVA, Hampton University, Virginia Tech, our research institutions. And in the course of that time, about $53 million has been brought back to Virginia for our institutions. That program, the Department of Defense Breast Cancer Research Program, is really innovative in that it uses consumer peer reviewers, so people who have had breast cancer sit on the panels to look at the research that is going to be funded. And to give an idea of some of the things that it has done, it developed Herceptin as a drug for the treatment of HER2-positive breast cancer and tamoxifen as a treatment for estrogen-positive breast cancer. Oh, wait, no, I have to learn how to do this. Okay, there we go. But yes, just to, toot your horn, thank you, General Assembly. After 3 years of working on this bill, it was passed unanimously by both chambers and signed into law this year that as of January 1st, all state-regulated healthcare plans will be prohibited from imposing cost-sharing requirements for diagnostic and supplemental breast examination. So that is diagnostic mammograms, breast ultrasounds, and breast MRIs. Just as you heard from Erin, we were getting a lot of calls to our office saying, I can't afford the $500 that they want me to pay to come back to see if this is breast cancer or not. They said it's $1,000. How am I supposed to pay this? And these are women who have health insurance. Research showed that 1 in 5 women would skip going back for their follow-up if they knew there was a copay involved. They just put it off. They said, I'm going to do it in 6 months. And as you can imagine, the later you wait, earlier diagnosis is the key to treating breast cancer successfully. And the longer you wait, there's just, the chance that the cancer could spread or that it's a costlier or longer treatment because you found it at a later stage. So we were just very fortunate to have great champions at the General Assembly and excited that that's happening. VBCF will be doing some, education about the new law in January because I know people will be curious to know if their insurance is covered. Unfortunately, we do expect that there will be in Virginia, just because of all the healthcare policy changes coming down the pike, more people who are uninsured, more people who are struggling to pay. And this bill is wonderful, but it covers state-regulated healthcare, not, if you have an employer-sponsored insurance, this does not cover that. So we're still working at the national level to get something passed that would do that, and we know how important that is. So I also wanted to just offer a few suggestions of things that the General Assembly and policy-wise that we could do to support women with breast cancer in Virginia. And one of the things mentioned is the Every Woman's Life program is a fantastic program, but it's very clear that there's unmet need. It doesn't serve all the women that it could serve. I think Christina mentioned that maybe 20,000 women are eligible and only 6,000 are able to get the screening. That is, we'd love to improve that. This summer, Erin referenced this, the funding for this program that's from the CDC was really delayed. There was a point where on the EWL website it said, after July 1st, we won't be able to provide these services anymore because we hadn't gotten the money to begin our state fiscal year. That combined with the president's proposed budget for the CDC this year completely cut funding for the CDC Center for Disease Prevention and Control, which includes the EWL funding and the funding for the Cancer Registry and Comprehensive Cancer. So with those two things happening, it's gotten us very concerned about the idea of we don't really have a backup generator if the federal funding fails. Virginia does not have a line item specifically for cancer funding, in particular the Every Woman's Life program, in terms of our thoughts, and some states do. They put more state funding towards these cancer programs. So it's something that we're really interested in encouraging the state to invest some line items for cancer programs in case we are up against the uncertainty of federal funding moving forward. The other thing, and again, Dr. Lewis mentioned this in terms of in terms of the obstetricians, OBGYNs, the workforce shortage in Virginia around medical providers, in particular oncologists, is something that we're concerned about. Several years ago, the American Society of Clinical Oncology estimated a shortage of around 2,200 oncologists in the U.S., and this is due to an aging workforce. A lot of oncologists are reaching a retirement age and increased demand. The good news is we're all living longer, and especially folks who have cancer are also living longer, and so they need oncology care for longer periods of time. And rural areas that already have difficulty recruiting healthcare professionals are going to be particularly impacted by this. So, some of the ideas, and Dr. Lewis mentioned some of these, loan forgiveness programs, scholarships, residency supports for oncology, and trying to target underserviced areas in the Commonwealth, and recruitment of physicians from racially diverse and underrepresented populations we think is important. We also wanted to highlight the great news that Senator Aird helped lead a bill being passed that establishes a research and clinical trial cancer consortium initiative. That was passed just this year, and we're really looking forward to the recommendations that will come out of that initiative, and also hope for some state funding to help implement maybe some of their recommendations, because again, as Erin mentioned, many patients, especially women of color, are not encouraged to participate in trials and don't know about them. We know it's important. And then finally, again, breast cancer is not something that's treated in a short amount of time. People often call our office and they've had to either quit their job or they are really struggling to pay for the rest of their life because they've had to take unpaid leave while they're going through treatment. A lot of the side effects of cancer treatment can be really brutal, and it's hard to keep up with everything and manage everything. Right now, about 73% of workers, 3.5 million workers in Virginia don't have access to paid family medical leave. 41% of private workers in Virginia don't even have any sick days, 0 sick days. So they can't take off time to get their cancer screening, and much less take off time to treat a cancer that they might have. So we just feel like medical leave would go a long way to helping cancer patients manage their treatment and finances. We know this is something that the General Assembly supports. It's been passed, a bill for paid family medical leave establishing a program in Virginia's past a few years, and we hope that this is the year, and we'll be there cheering that on. I could probably go on and on about some other ideas that we could have for things to help around the breast cancer specific space, but we really appreciate the opportunity to be here and look forward to talking with you more and helping in any way we can. So thank you. And there's our contact information.
Thank you so much, and thank you for all the work that you're doing, and thank you for making the connection between healthcare and paid family medical leave that many people here have worked across the board. And I have a very sneaky suspicion that we'll have a little different outcome in the next few months on that issue. So thank you so much. With that, we have time for 1 or 2 questions from the commission, and then we are going to go for public comment. Delegate Tran.
Thank you so much, Madam Chair. I had a couple of questions, and if I can just ask them all at once, and maybe whomever is the best person to respond to, or we can follow up offline. I was particularly, so I would love to hear your thoughts on why it seems to be that there are more women who are younger being diagnosed with breast cancer, and whether that is because screening has information about screening has improved for some, and then so therefore they're getting those screenings and getting that earlier diagnosis, or if there's something else. And I think there's been several articles about incidents of cancer just generally happening to younger folks. I was interested in the comment about the special license plate, and if that is actually bringing in significant resources for you to do to run your programs. I was also interested in some of the data that particularly mortality based on race and ethnicity, that it did not include Asian American Pacific Islander women and Indigenous women in Virginia. Would love your thoughts on that. And then the last thing is the end of the drive-through mastectomies. I know somebody who had a double mastectomy and reconstruction surgery and was sent home the same day as an outpatient. And so I would love, and I was just texting with her, and she thinks that maybe it's because of the type of procedures she had, but would love your thoughts on whom the end of drive-through mastectomies actually are applying to, since this just happened within the month. Thank you so much.
So to answer your question on are younger women getting diagnosed with breast cancer more often? So it is not only feeling like that, the statistics are bearing it out. I think last I saw it was under 2% increase, but it's still something that people are paying attention to. Women under the age of 50 are getting diagnosed with breast cancer. And I know we mentioned, we had heard from Dr. Lewis earlier today about women who are having babies at a later age. We're seeing more now that the pregnancy postpartum population and the breast cancer population are touching a little bit more closely. And that can cause some confusion when it comes to symptoms of breast cancer. Tend to be things like lumps, redness, rashes, can also be things that people who are breastfeeding experience, mastitis, things like that. So we are seeing that. It's not only in the US, but it's also worldwide. There's not really a good consensus as to why at this point, but that is something that is being noticed and discussed.
In terms of the pink ribbon license plate, it brings in around $100,000 a year to VBCF, which is fantastic. Helps with printing of all of our educational materials. I think we got it in 1990. I think it's
one of the first ones.
Yeah. I can't remember the date, but yes, it's fantastic, and so we are so appreciative that the General Assembly approved that. In terms of the drive-through mastectomy, I suspect it might have to do with the kind of health insurance that she has. This bill was passed in 1998. I am imagining that it applies to state-regulated healthcare plans, so it may be that she has, employer-sponsored care. But I'm going to follow up with you so I can try to help and make sure that something isn't going awry. That doesn't sound great.
All right, and then I appreciate your question about how we break up race ethnicity for the cancer registry. So historically, I just started with the registry at the end of April. Previously, we had only been reporting out Black versus white. This is even the first year that we've broken out by Hispanic for ethnicity. I have pushed, and we are continuing to improve our reporting, that next year our goal on our dashboards online are to break up by the other ethnicities like Asian American, because clearly we do have those. There were concerns before about suppression levels because of the smaller population size, and there'd be a lot of suppression, but just because there's suppression at some localities doesn't mean we don't share it. So that's something we're working on for our data dashboards next year. Mm-hmm.
Thank you. And we have time for one more question. Yes, Ms. Shorter.
Thank you, Madam Chair, and all of you here today with your well-researched presentations. My question is, your research continues to, and I'm looking at my notes, highlight the immutable fact that Black women are diagnosed with more aggressive forms of breast cancer, often due to delayed detection and inequitable access to consistent screenings. So beyond the reimbursement reform that's clearly needed, how can Virginia legislators integrate improved racial equity metrics into state health policy, such as mandating parities in provider reimbursements, expanding culturally competent care networks, and funding targeted community-based screening initiatives?
So thank you for your question. One thing going out in communities that I've heard a couple of anecdotes from Black women who've gone through breast cancer, who they mentioned that they were diagnosed through one provider, and then they took some time to find the right cancer treatment team for themselves because they wanted to be sure that they were treated by someone they felt comfortable with. Unfortunately, what that can also lead to is delay in the beginning of treatment. I was working with a national group to host a triple-negative breast cancer education session in, I believe it was Hampton last year, and we could not find a Black oncologist in the eastern part of Virginia. So, that was a challenge. Now, it's something that we have discussed, and I've heard from patients that we need to have more diversity in our healthcare workforce, particularly when it comes to cancer care. When I mentioned about clinical trials not being offered, white doctors are more likely to not offer because they assume that the patient their Black patient is not going to say yes. But Black doctors will offer to their patients, and then their Black patients will agree at a roughly similar rate, is my understanding, to white patients when they're offered the opportunity to participate in clinical trials. So we definitely have a disconnect there when it comes to folks who are seeking cancer treatment and people who are providing that cancer treatment. So we think that providing additional support to people who are entering the healthcare workforce in loan forgiveness and more residency slots, things like that, could boost the diversity of the healthcare workforce, which would hopefully address some of these issues.
Thank you so much. Thank you for that informative presentation. I want to, before we go into our subcommittee assignments and public comment, we do have a committee, the Life Experiences Committee, that also has a sort of scope on cancer, was what was in the notes. But if there is a recommendation to specifically put breast cancer as an item for that subcommittee, open to that as well. So it's been moved and second to add breast cancer specifically to the Life Experiences Subcommittee. All those in favor shall say aye. Aye. Any opposed? All right, thank you all so much. I hope you can stay with us for just a few minutes, and then we are going to close out this committee. Next up on our agenda is an update on our subcommittee assignments. So Chair Lucas and I have, based on feedback from the committee, come up with a work plan and had some great volunteers step up. Some great volunteers step up to lead our subcommittee chairs. As a reminder, our goal for this committee is to have recommendations by December 1st. That is a great goal for us, but we will continue working until session to get a great set of recommendations from this commission. And so with that, we have the Preventative Care Subcommittee, which is going to focus on, little girls become women, and young women need a lot of support as well. So we have the Preventative Care Subcommittee that will be led by Delegate Tran, and those who have signed up, not been voluntold, Dr. Proctor, Ms. Shorter, Ms. Sutton L., and myself on preventative care. Then we have the Growing in Grace Subcommittee that will be led by Senator Locke. And that is focused on those issues of aging that have been ignored, especially peri and menopausal issues, osteoporosis, and other issues in aging. And that is Ms. Brimby, Delegate Tran, Ms. Brayboy, and Senator Lucas. And then third, we have our technology. And, not to prolong the meeting, but there is some great technology, AI, emerging in the breast cancer space. So we're hoping this committee will address that, as well as affordability and access to those technologies. And that is led by Senator Aird. And we have Delegate Anthony, Delegate Tata, Ms. Brayboy, and Delegate Tran. And then finally, we have life experiences led by Delegate Anthony with Senator Perry, Delegate Kent, Ms. Sutton L., Ms. Brimby, Ms. Shorter, and Delegate Simons. And if there are any volunteers that I may have missed, please let me know. But those will be our 4 subcommittees for this year, and we will be working on we have approved a virtual meeting option as well, because as women, we have a lot of responsibilities, right? And so those subcommittees will have the opportunity to meet in person or virtually. And so for those listening online, you can visit the commission's website. If you cannot join us, you can join us virtually. You can also email us and make recommendations. We really want to be a space where women's health issues are prioritized, and we welcome folks from across the Commonwealth to join us in that mission. And with that, we will turn to public comment. If there's anyone here for public comment, please step forward, and we will give each person 3 minutes. I am not in the Senate, so I do not know how to turn on the timer, but I promise you I will be fair.
I asked ChatGPT to make it 3 minutes. So
Perfect.
Hi, my name is Deanne Graham. In the 1990s, I was leadership in the grassroots movement that culminated in the licensing of midwives in 2005. I'm a master's level patient advocate with 35 years of experience, and more recently a Virginia Humanities Fellow, where I am writing the history of Virginia midwives for a book and the women they served. Today, I'm pinch hitting for the Virginia Interfaith Center for Public Policy, asking for your support for a budget amendment to expand access to midwifery care to mothers enrolled in Cardinal Care. Right now, many mothers on Medicaid who wish to receive care from licensed midwives, whether at home or a birth center, face significant barriers. Under the current policy and reimbursement practices, licensed midwives are often unable to bill Medicaid until very late in the pregnancy, sometimes not until 36, 38 weeks. This makes it financially unworkable for the midwives, and they don't want to be taking in women that close to the end of their pregnancies, because the hallmark of midwifery is continuity of care. Some managed care organizations have attempted to include midwives, but they require malpractice insurance premiums that are not feasible for small midwifery practices. The result is not that midwives are unwilling to serve Medicaid families, it's that the system structurally prevents them from doing so. This challenge has a new urgency. As of December 19, the Farmville hospital-based midwifery practice has closed, leaving a wide rural area with dramatically fewer maternity care options. In many rural communities, licensed midwives are the only nearby maternity care providers. If Medicaid reimbursement remains inaccessible or delayed, these practices cannot stay viable and maternity care deserts will deepen. Why does this matter? Because the research is clear. Continuity of care saves lives. When a mother builds a relationship with the same midwife or small team throughout pregnancy, birth, and postpartum, we will see lower rates of preterm birth. One of the midwives I am writing about in my book, over 50 years, served 500 sets of twins, and all but 2 went full term. So ChatGPT let me down on the 3 minutes, but I think I got my point over.
Thank you for that. Do you have a cost on that budget amendment?
No, I am pinch hitting,
Hitting.
as I said, because the intern midwife had a birth she had to go
I
to.
completely
And I just went-
understand.
I
And
am so
will-
much right now comfortable with 18th century archives at the Library of Virginia. In about 6 months, I'll be back in the 21st century.
I understand. Well, we will certainly be on the lookout for that budget amendment and those details, but thank you so much.
Women with low resources deserve bodily autonomy also.
Absolutely. Thank you. Any other person for public comment? And with that, I just do want to take a moment to just come back to the commission to see if there are any closing remarks from members. Seeing that, I will entertain a motion to adjourn. So moved. The committee is adjourned. Oh, let me use this.